Hello, hi everyone. I'm Dr. Ho Ting Ki. Today we shall learn about shortened dental arch concept. I'm sorry that I have to do these recording lectures online instead of having the physical lectures because I'm on my long MC during this period. So to prevent the disruptions of your teaching and learning, so I think we just proceed with online lectures. So the learning outcomes for this lecture are to describe the rationale of this shortened dental arch, to look at the necessity to replace the missing teeth, and what are the oral health goals from the WHO for the nations. Secondly, we want to discuss the management for the shortened dental arch patients. So first of all, let's think about why do we need to replace the missing teeth. Okay, it's very commonly we want to replace the missing teeth because we want to improve the chewing functions. As we know, if you have less teeth in the mouth, your chewing capacity reduces. To improve the aesthetic and appearance, especially if you have missing teeth on the anterior. Okay, we want to prevent the occlusal instability. In what way the missing teeth will cause occlusal instability? It could be because of the mesial or distal shifting of the teeth on the same arch into the edentulous space. So for the opposing arch, when they don't have teeth on the opposing arch, so the teeth may over-erupt into the edentulous space as well. Right, then you want to prevent the TMD problem because when you have missing teeth, the teeth are not contacting each other, so your mandible may need to slide anteriorly to achieve occlusions. So in long term, some people may develop TMD. However, this evidence is not very strong though. Right, then to improve the speech, as we know, the teeth are important for us to pronounce for the phonetic to pronounce the words correctly. So if you don't have if you have got missing teeth, especially the anterior teeth, then it may impact your speech. And lastly, to replace the teeth, hopefully it can improve the psychosocial well-being. So when we look at, there are so many, like the importance of replace missing teeth. So is it necessary for us to replace all the missing teeth? So before you plan your prosthetic treatment, there are questions that you may need to ask them to get to know more from your patient whether if there's a need to replace the teeth or not. For instance, if they have any problem chewing the food, or they have any issues on their appearance, on their aesthetic arising from the missing teeth. The appearance concern, it may not only if the patient have missing the anterior teeth. I have experienced patients missing the posterior teeth. They come to see me. They want the dentures to bulk out, their cheek a bit, because when you lost the posterior teeth, they say that their cheek has shrunk in, so they look like a bit old. So instead of like having a Botox, or whatever this cosmetic thing on the skin, they say the dentures may face look more fullness, and then it look more youthness. And in fact, at a certain degree, I think it is true that for some patient, if you restore the posterior teeth, then the patient actually look younger. Then the patient have any discomfort arising from the missing teeth, and any evidence of occlusal instability as a result of a missing teeth. So if you were to provide the treatment options for the patients in the reduced dentitions, these are the treatment options. What do you mean by reduced dentitions? Which means it's not fully dentate, it means you have some missing teeth. These are the treatment options that we could provide for our patient with missing teeth. Some of them are the common treatment modality. Some of them are not so common, and it may require higher level of training for the dentist before they can provide the treatment. However, we can still discuss with the patient of such a treatment. So let's go through the treatment options. So in the first is to restorations and maintenance of a functional dentition with no prosthetic intervention, which means you don't provide any prosthetic thing for the patients. However, you try your best to restore whichever that the patient has at the moment. So number 2, we want to give the patients removable prosthesis. It can be acrylic, it can be metal based, commonly cobalt chrome. It can be removed partial denture with precision attachment. I'm not sure how much you're exposed to this prosthesis, but I have some photo later on to show you what is removable partial denture with a precision attachment. So you can also provide restorations by the means of fixed prosthesis, which means the patient cannot take up by themselves. You can have the conventional cantilever bridge, racing bonded cantilever bridge, and then it also can provide a higher level of treatment, which is the implant retained prosthesis. So it can be implant supported crowns, implant supported bridges, and implant supported RPD. So these are the photos showing the conventional acrylic, and these are the cobalt chrome RPD. I'm sure you all are very familiar with this one, right? Then this is one of my patient, RPD with precision attachment. So this is the precision attachment. This attachment is secured in the lab together with the prosthesis of the patient. In this case, this is the crown and bridges work. So this precision attachment, it linked together with the patient's crown and bridge work. So it's cement into the patient's mouth, and then you have a removable partial dentures coat into the place. This attachment, in long term, it may get loose, or the loose can be here, worn out, or the attachment inside the dentures can be worn off. So when this get worn off, then you may need to replace RPD. In this case, you can see that the dentures is like click into this attachment. There's no retention arm at all. So it's actually provide more retentions for the patients. This is the example of the mesial cantilever RBB. So RBB, because you all haven't gone through the lectures for the fixed prosthodontics, I just briefly go through all these terms. RBB, in the layman term, sometimes when I tell patient, I say it's a sticky bridge. So like a sticky, you just need to stick on it on the tooth next to it. The tooth next to it we call abutment. This is abutment. Okay, you need minimal prep or no prep at all. Okay, so this is the pontic. The pontic, it has a retainer, a metal retainer, stick on the abutment tooth. How to stick? They use a very strong resin cement of this bridge onto the abutment tooth. That's why we call resin bonded cantilever bridge. Okay, so cantilever is also another term that you may not familiar with. It meaning we only use one abutment on one side. If the pontic is located mesially to the abutment, so we call mesial cantilever RBB. So if the pontic is located distally, for instance, you have missing 6s, I have 6, and then I stick it on the 5. So this is called distal cantilever RBB, right? So RBB is one of the most conservative fixed options to replace a missing tooth. It normally used in a very small edentulous space. Then we have conventional cantilever bridge. Again, the cantilever means you only use one abutment to secure your prosthesis. Okay, one abutment. If it's 2 abutments, we call fixed bridge. So cantilever is you use only one abutment. So conventional cantilever bridge is where you need to prep your abutment like a crown. Okay, so into a smaller size. Then only you construct a cantilever bridge and you cement the bridge on top of the abutment. So in this case, because the tooth that you're going to replace is distal to the abutment, that's why we call distal cantilever bridge. In general, we don't really encourage or we don't really use distal cantilever bridge in our treatment plan. It's either distal cantilever RBB or distal cantilever bridge, because when patient occlude, right, the posterior teeth will bite first, will have the occlusion first before the teeth anterior to it. So which means you will have the occlusal contact on your pontic before the abutment tooth. This is not so healthy for the abutment tooth lah. So that's why in most of the cases we don't really use the distal cantilever bridge. But however, in this SDA concept, let's say patient don't have 6 or don't have 5 and above, so you may want to add only one occlusal unit for the patients. So this can be incorporated into one of the treatment options, which is the distal cantilever bridge for the patient to add one more occlusal unit after the last tooth. So the next one is a dental implant supported bridges. In this type of treatment, you need a longer edentulous space to put 2 implants with a space in between, and then you make a fixed bridge to fix on top of the implants. So this is we call fixtures, the implant fixtures. So you just put 2 implants. So if you, let's say if you're only missing 7 or you're only missing 6 and 7, so this is not an option. Or if you're missing like probably 4, 5, 6, 7, then probably this is one of the good options, because you have a long span of the edentulous area, and you need, because for the bridge we need more space, okay, to place this prosthesis. This is also not something that we commonly do. We have not a common treatment options, which is this dental implant supported RPD. In this journal, I cropped this photo from this journal. So they call implant assisted RPD, IARPD, whichever also can, as long as you understand the RPD is supported by the dental implant. It is still removable, so you still need to ask the patients to remove the denture at night. You know, for the normal free end saddle RPD is not an easy treatment or not so well accepted by the patients as one of the treatment modality, because the support on the tooth and the support on the mucosa are different, the loading stress are also different, so the denture tends to move more. That's why patients normally they claim that it is not comfortable with the tongue movement, everything. A lot of time patients don't really like it for this free end saddle RPD. To overcome this problem, they have this implant supported RPD or implant assisted RPD to help with the problem of this free end saddle dentures. So they place a minimal number of implants at the back of the mouth, and then they converting the bilateral free end saddle dentures into like so-called Kennedy class 3. So they have like a support at the back, which provided by the implants, so that the dentures will not flip around the fulcrum area. Okay, so this is also one of the treatment options for the patient which has this shortened dental arch with the missing teeth at the posterior region. Let's look at the strategy in management of the reduced dentitions and how we choose which decisions or which treatment options to provide for the patients. I would say the decisions we have to based on many factors. So that's why the treatment provided should be a customized treatment plan for each of the patients. So we need to assess the patients based on their focus expectations, based on their psychological factors, medical social history, history of denture wearing, the patient's finances. Then if you look at the teeth, you need to check the periodontal conditions of the abutment teeth and also the restorative condition of the abutment teeth with the help of the radiographic examinations. Let's look at the common treatment plan that we propose for the patient, which is the dentures. Sometimes we propose a denture options for the patients, and then patients are quite reluctant to accept this treatment modality because there's rumors to say that these dentures are going to further make their teeth worse with more caries and more tooth extractions. Yes, the studies have reported that there are increased incidence of caries and periodontal disease when the patient is wearing the dentures. But this happens especially when the patient is not meticulous in taking care of their dentures, and also they don't really practice good oral hygiene practices like brush 2 times per day and using the interdental cleaning like floss or interdental brush. So if the dentures is well maintained and also patient is meticulous in the oral health care, research has shown that it's unlikely to cause a dental caries and periodontal disease. Besides that, sometimes the way how we construct the dentures or the type of the dentures we provide for the patient may actually cause more plaque retention. Like in this case, you can see that the margin of the dentures is actually below the survey line, and in fact there is a gap present between the dentures and also the tooth surface. So in this case, you are not helping the patients, but you make this area more plaque retentive. Therefore, they are difficult to clean. It make the plaque easily stuck here, and it makes the situation worse. So now, do we propose treatment? Or do we need to replace all missing teeth? Let's look at what the WHO expert committee says in 1992. So in 1992, there is a group of expert committee gathered together, and they come up with the document saying that the aim of the oral health care is to maintain at least 20 functional teeth and not requiring any prosthesis. So they propose that the aim for it is we should keep at least 20 functional teeth, means 20 teeth that is in occluding lah. Then if there is not demanding functionally or aesthetically, or not causing any occlusal disharmony, and not causing any myofascial pain or problems. If you have these 20 functional teeth, the teeth that you lost or missing should not be replaced. And this concept of shortened dental arch, teeth present from bicuspid to bicuspid, seems to be a realistic approach when the caries level are high and resources are limited. So in simple terms, the WHO goal for oral health, it says that the retentions of a healthy natural functional dentition comprising of not less than 20 well-distributed teeth and not requiring any prosthesis. So let's look at this photo on the left hand side. So this patient or this model shows that this patient has 20 functional teeth from premolar to premolar, which is occluding on each other. In this case, you have 20 teeth, but however, it's not so ideal, or it's not ideal at all, because patient have poor occlusion, which the contacting teeth probably is only canine to canine, which is 6 occlusion pairs. So in these 20 teeth, they also name it as a shortened dental arch, where the patient will have adaptive capacity to maintain adequate oral health. So with the 4 occlusal unit, which is the premolar to premolar, this is considered 1 occlusal unit, 2 occlusal unit, and another 2 on the other side. Okay, so preferably in the symmetry positions. Right, the National Health Service like KKM in Malaysia or NHS in UK, as well as the national insurance system in other countries, are actually required to pay or to subsidize all dental treatment. Then with the increased populations among the elderly worldwide, so I would say that we have more patients retain their natural teeth longer, and we have more elderly population which needs treatment as well. So with this increase of tooth retention, population growth and aging, the burden of the oral conditions will continue to rise. Therefore, we need to consider that should we restore all missing teeth to achieve a fully dentate condition. This leads to the introductions of the concept known as a shortened dental arch, where possibly they say that this shortened dental arch, you do not need to restore your teeth into fully dentate, which is from like second molar to second molar, from 7 to 7. Let's look at what is a shortened dental arch. Shortened dental arch can be defined as the type of dentition with reduced or even absence of the molar and or premolars. So Keisel and his colleague in 1981 proposed this concept. So in the Keisel paper, they only consider the posterior teeth. So they say that 4 occlusal units are needed for sufficient masticatory function and a healthy occlusions. So preferably in a symmetrical pattern. So if you have 1 pair of occluding premolars, it consider 1 occlusal unit. If you have 1 pair of occluding molars, then it consider 2 occlusal units. For premolar is 1, for molar it is 2. And then this Keisel further classify the pattern of missing teeth or the pattern of teeth present into different class. You don't have to memorize all these classification, but it's good for you to understand like the pattern of missing teeth or the pattern of the teeth present. Okay, and how many occlusal unit are there if there are such a teeth present inside the mouth. So there are 4 classifications. Let's look at class 1. Actually, this one is not a shortened dental arch at all. The patients don't have any shortening. Okay, the premolars, the pairs that is occluding, probably patient have like 3 or 4. Probably patient just missing 1 premolar. Okay, all the molars are present. Okay, so if the patients have 3 premolars present, let's say 1, 2, and 3. So posteriorly, you have 1, 2, 3, 4, 5, 6. This one missing. 7, 8, 9, 10, 11. So you have about 11 occlusal unit. If all your premolars are present, you have 12 occlusal unit. For this shortened dental arch concept, the requirement is all the anterior teeth from 3 to 3 must be present. So the 3 to 3 must be present, so it provides 1, 2, 3, 4, 5, 6. It provides 6 occlusal unit or occluding pairs. So in total, posterior and anterior, you have about 17 to 18 functional occlusal unit. So let's look at the class 2. The class 2, the shortening is asymmetry, meaning you got 1 arch longer and the other arch is shorter. The premolar patterns can have 2 to 3 or you can have 3 to 4. The molar, some of the molars also missing. So similarly, you count how many premolars present. Okay, let's look at this one. If this is the 2A case, you have 1, 2, 3, 4, 5, 6. So you have 6 occlusal unit. If you have 1, 2, 3, 4, 4 premolar and 1 molar. So 4 premolar and 1 molar is 6 occlusal unit. Okay, if you have additional 1 molar here, then you have 8 occlusal unit. Plus the anterior teeth, in total, you have 12 to 14 occlusal unit. For class 2B, you have more missing teeth. So for the premolar, you probably have like 2 or 3 pairs of premolars, or molars, you have only 1 pair of molar. So the total occlusal unit, it could be 4 to 5, and then including the anterior one, in total you have 10 to 11. For the the WHO goal that we mentioned just now, the goal is have a 20 functional teeth present. So 20 functional teeth, then you have 10 pairs. So up to now, is still all consider achieve the WHO goal for the oral health lah. They have at least 10 pairs of at least 10 pairs of functional occlusal unit. Then we look at this class 3. Class 3 is a symmetrical pattern. So in 3A, 6 to 6, 6 to 6. So you may missing 1 premolar, but you have present 2 molars. So the occlusal unit on the posterior is 7 to 8 according to the Kaisel. But in total, you have 13 to 14 occlusal unit. Okay, 1, 2, 3, 4, 5, 6, 7, 8. Okay, in this case is 8. So if you lost 1 premolar, then it's 7. So, and then including the anterior teeth, you have total of 13 to 14. For the class 3B, you have further loss of the molars. Then you have keeping the premolars. Right, so say if we have 4 premolars, no molars, then the total occlusal unit is 4. Then the total occlusal unit including anteriors, you have 10. That is actually the so-called the goal that we would like to, or the WHO proposed at least 10 occlusal or 10 functional occluding pairs. These are the example of shortened dental arch. This is the last classification, which is class 4. They call it extreme shortened dental arch. When it calls extreme, means you have lost more of the teeth. You have lost more. It's only 3 to 3 present, possibly with 1 or 2 premolars. So if you have 1 premolars, then you have 1 occlusal unit. If you have 2 premolars, then you have 2. And then the total occlusal units is actually below the below what WHO proposed. Right. In the Kaisel research, he actually so-called classified the participant into 2 type of patterns in terms of the oral functions as opposed to the number of occlusal unit. This number of occlusal units, if we talk about Kaisel, is the only the posterior, the number of occlusal unit at the posterior region. So in his research, he's found that in the type 1, or in this group of people, they have adaptive capacity until so when when you are fully dentate, your occlusal function is 100%, and then as you lose the teeth, you reduce the oral function. Then you have the adaptive capacity until you reach the last 4 occlusal unit. The occlusal functions drop drastically, right? Drop drastically. And then another type of the patient, it reduced the oral function according to the occlusal units progressively, straight line. And then in this case, it proposed that the 4 occlusal unit is the minimal that proposed for the patients to have like good oral function or 80% oral function capacity. Anteriors and premolars are the strategic part of the dental arch because it provides the aesthetic value for the patients. So if you lost these teeth, you have a negative impact on the aesthetic, and most of the time the subjects, they want to have a prosthetic replacement, and also extreme shortened dental arch which you don't have any occlusal unit at the posterior, okay, may increase risk of occlusal stability. Therefore, they propose this shortened dental arch concept to provide the direction of treatment efforts and resources at the preservations of the anterior and premolar teeth. Ideally, you keep at least until premolar. When we talk about shortened dental arch, straight away you think about you have at least a minimum of 10 occluding pairs, including the anterior teeth. So 10 occluding pairs, 20 functional teeth. So it's from the premolar to premolar. What are the advantages? You simplify the restorative treatment and maintenance, meaning you keep the 10 teeth and then you don't provide any prosthetic treatment to restore the missing teeth. Okay, so you simplify the treatment, simplify the oral hygiene maintenance. Patient don't have so many teeth to brush. We hope that we want to increase the prognosis of the remaining teeth when the patient is motivated to maintain the remaining dentitions. So in which case we can use this shortened dental arch concept. Don't aim to restore the patient into fully dentate. We can use this if the patient has the caries and periodontal disease confined mainly to the molar teeth. Anteriors and also the premolar are pretty good, so they have a long-term prognosis, okay, good long-term prognosis, and also patient will have limited finances available for the restorative care. Instead of paying all the money to restore the lower dentures, which patient may not even want to wear it, or patient may even find it uncomfortable to wear it. And also in cases where we don't see patients suffer from any occlusal trauma, there's no heavy contact on the remaining teeth. So how we know if the patient have occlusal trauma? We can see the filling keep on fractured, okay, the dislodged filling, fractured filling, then the periodontal support might be compromised and cause the mobility of the teeth, because when you have occlusal trauma, it can cause this additional load on some of the teeth and cause mobility. Then patient might suffer from dental pain, okay, and patient might have a tooth surface loss lah. Okay. In which case we say that it's contraindications, or we don't propose this shortened dental arch on the patient where these have a marked dental-alveolar malrelationship, where patient has a severe class 2 incisor relationship or severe class 3, where the front teeth will never meet at all. Means if the front teeth, upper and lower teeth, don't have functional occluding contact, then patient cannot eat lah, or there's no chewing capacity for the anterior teeth. Then if you only keep premolar to premolar, means the patient only use the dead 2 premolars for the chewing function. Of course, in this case, it doesn't work for the patient. Then patient have para function, which probably like grinding at night, because this will cause the severe tooth surface loss. Then patient got pre-existing TMD problem. So if you don't have posterior teeth to provide a good occlusal contact, patient might slide their jaw forward to get more good contact, then this may promote more TMD problem. Advanced pathological tooth wear, just now we mentioned the tooth surface loss. Advanced periodontal disease, where you have reduced bone support. For your anteriors, you already have reduced bone support and you don't have posterior teeth to provide posterior support. You further increase the occlusal load on your anterior teeth, and then it may cause more mobility on the anterior teeth lah. And also for patients at a very young age, at the age are under 40. Actually, for the age of under 40, there's only one paper says that in average, in some of the paper they mentions 65 is the cutoff point. Only one paper mentioned 40 years old as a cut-off point. So to be honest, there is no absolute age limit for to apply this SDA, but I would say that this would not be suitable for young patients, okay? Because patients still have a long way to use their teeth. Patients only have premolar to premolar at a very young age. The teeth probably need to continue to service them until like 80 years old. Say if they could live until 80 years old. So there is a possibility that the teeth might deteriorate earlier than expected. Then you will end up edentulous at the end of the day. Again, this shortened dental arch, right? It's just a concept. It's just a concept. And it's what we propose, or what the WHO or what the researcher they propose, that it could be okay to keep the teeth from premolar to premolar, and this especially work for elderly patients. But there is no conclusive statement to say that you must restore or you mustn't restore the missing teeth at the posterior if you are a young patient. Is that you provide more harm or you provide more benefit if you don't provide any prosthesis for the patient with the shortened dental arch? So there is a few research that provide some evidence on the patients with shortened dental arch. Let's look at it. Okay. Sarita et al. 2003 has looked into the research, the occlusal stability among the SDA participants or patients. Okay. So in her research, that you can see that in the patient where has extreme SDA, where it has 0 to 2 pairs of premolars, the presence of more interdental spacing, more occlusal contact on the incisors, and more vertical overlap compared to a fully dentate arches. Okay, so because of this more occlusal contact, more overlapping, it has high prevalence of occlusal wear and mobile teeth. Right, so if the patient has 3 to 4 occluding premolars, which is the common SDA that we find, it's only present with more interdental spacing. Okay, only in the older age group you have more anterior teeth contact. So the age is consistently associated with increased changes in the occlusal integrity. So which means in a younger patient, the occlusal integrity was okay or better, and as it goes older, patient has more changes in the occlusal integrity. So in conclusion, the authors conclude that the signs of increased risk to the occlusal stability seems to occur only in extreme SDA, where no such evidence was found for intermediate categories of SDA. So it actually helped us to make decisions like should we provide any prosthesis for the patient if patient have lost molars and premolars. So how many teeth lost, then only we will consider to provide more occlusal unit for the patient. Sarita also looking at the chewing ability among the SDA patients. So in Sarita's research, it was noticed that SDA patient with intact premolars means you have at least 5 to 5 and also at least 1 occluding pairs of molars. So this is enough, or this could be sufficient. Patient of this group has sufficient chewing ability. So let's say you have missing some of your premolars, or the missing is at the asymmetry arches, you have short side, which is missing up to premolars. The other side, you have more occluding pairs up to molars. So in the patient in this group, you might have slight impairment in chewing ability, especially for hard food. Okay, so if the patients in the extreme SDA group with only 0 or 1 or 2 occluding premolars, the chewing ability is severely impaired. Okay, means it will affect your chewing ability if you don't have complete premolars present. This is a very old research, 1990. Okay, they look at the survival of prosthodontic interventions. So they have patients with they restore the patients with a distal cantilever bridge and also with dentures. Okay, so this distal cantilever bridge is up to the premolar, and then if the patient have missing teeth posteriorly with free end saddle, they provide patients RPD, restore up to molars. So in these two groups of patients, they found that patients with the dentures have higher risk to get caries, and they have experienced deteriorated occlusal and functional conditions, and this patient receive the dentures actually need more dental and prosthodontic treatment. So the 5 years failure rate for the dentures is actually higher than the fixed partial denture group, which is the cantilever bridge patients. However, they have not produce or conduct any statistical analysis to compare these failures. Okay, in the simple terms, the patient wearing dentures is like more problem. Then as we improve, instead of a cantilever bridge, then we have more resin cement, and also RBB has come into this one of the prosthodontic treatment options. In 2007, instead of cantilever bridge, distal cantilever bridge, they provide the patient with this RBB, okay, and they restore up to the second premolar. Similarly, in the denture group, they provide cobalt chrome dentures to restore the free end saddle. So in 5 years' time, the survival for the dentures is lower compared to the RBB. The RBB show a lower hazard rate, but it's not statistically significant. In this research, you can see that the number of follow-up appointments and treatment needs for the RBB group and dentures are very different. In RBB, they only need to come back to the clinic 39 times compared to the dentures patients 78 times. So they conclude that RPD patients, although if you can see, it looks like RBB and RPD group are not very different in terms of the hazard rate, but it seems like patients in the dentures need more maintenance visit. So in that, they actually support the use of RBB in restoring the SDA for elderly patients. Now let's see the research about sustainability of the shortened dental arch. So this research carried out by Gerritsen 2013 in the Netherlands. I would say this research is quite a good research because it has good number of patients record, and they record the patient's data from 27 years to 35 years. Means they follow up the patient record up to this 35 years, which I would say the record is quite complete to make a conclusion or about the findings. So they include 23 subjects of the shorter dental arch, 23 subjects with a complete dentate, and also 13 shortened dental arch patients with a removable partial denture. They find out that these shortened dental arch patients had a higher risk of needing the first restorative treatment on the anterior and premolars. And between the patients' shortened dental arch with dentures and without dentures, there's no significant difference. With regards to the risk of tooth loss, shortened dental arch patient has a higher risk to lose their premolar compared to the complete dentate patients. There's no significant difference for anterior teeth loss among the groups, and there's no increased risk of tooth loss with the patients wearing or not wearing the dentures among the shorter dental arch patients. So which means found that there's no difference for the risk to get the restorative treatment, the risk tooth loss between the patients wearing or not wearing the dentures among the shorter dental arch patient. The clinical implication, they propose that the shorter dental arch patients are considered a long-term risk patients, so it should have the continuous and intensive dental monitoring to avoid further tooth loss. This is quite a new research 2024 by Yoshimoto. They look into the oral functions among the shortened dental arch patients, which is to look at the number of functional teeth, masticatory performance, occlusal force, oral cleanliness, dryness, maximum tongue pressure. It carried out 2 years, and it include the 257 patients with complete dentate and 21 patients with shorter dental arch patient with no wearing the dentures. In this, they found that the patient with a shortened dental arch has a greater tooth loss over the time. However, the oral function that they test is deteriorate at the similar pattern compared to the patient with the complete dentate adults. It deteriorates over the time, and the pattern of deteriorate is actually similar to the patient with the fully dentate. Therefore, the shortened dental arch does not lead to a major function decline within the study period. And they claim that the patients with shortened dental arch may maintain acceptable oral function even without the full prosthetic restorations, and the prosthetic treatment like implant, crowns, dentures should be tailored based on the patient's goals and needs. This research looking into the oral health related quality of life. So we want to know, yes, we say that the oral function is not much of difference, but how about the quality of life? Oral health related quality of life that they look at are functional limitation, physical pain, psychological discomfort, physical disability, psychological disability, social disability, and handicap. Then on Wolford, they have very small number of subjects, 10 in each group, to look into the oral health related quality of life. They have group 1 with patient wearing the dentures. The dentures are actually with the precision attachment. And then in the group 2, they provide the patients with crown and distal cantilever bridge, and they restore up to the premolar occlusions. For the dentures, they restore up to first molar. At 6 months and 12 months follow-up, and each group, they realize there is improvement of quality of life. However, there's no difference among these two groups. So whether you provide a patient with the dentures with precision attachment or crown and distal cantilever, they realize that there is no difference in quality of life. Then more patients are included in Brazil in a more recent study by Antunes. They look into the patients with the shortened dental arch with or without the prosthesis versus the fully dentate patient. And they realize that there's no significance in the prevalence and severity of oral impacts on daily performance index after they adjusted with the social demographic and the dental outcomes. So they realize the difference in the quality of life between the SDA patients and those patients with more teeth are mainly because of the oral conditions such as the periodontal disease and untreated caries. Since they found that, therefore they propose that more allocation should be channeled towards the preventive, diagnostic and restorative services, and this could help the middle-aged adult to maintain the functional dentitions and support the healthy aging by preserving the oral functions and improving a long-term oral health outcome. So in a simple words, to maintain more teeth in the mouth. So after I present to you those research that's related to shortened dental arch, it seems like it's quite inconclusive, like whether the dental treatment provide any additional benefit for the patients. So and also if the dentures could provide more harm to the patients, I would say is actually quite inconclusive. Now let's look at the recent systematic review by Mandola et al. In 2017. So this collect the research from the 1980 to 2014 to look into how many research that actually in favor or against the SDA. As you can see that the numbers of the research pro the SDA remain similar, and in the recent years the number of research against the SDA has increased. You may want to explore further in each of the paper from the systematic review to read what are the things that they research and why the research or the result against the SDA. And overall you can see that the number of research that is in favor of the SDA are actually more than the number of the research against the SDA. So now we look at what are the factors associated with the number of remaining teeth. There's a lot of research on this topic lah. What are the factors that are associated with the number of teeth inside the mouth. I just simply pick one which I think possibly is quite complete, this one, because this research it has this survey and also clinical examinations, and they carry on 3,255 Korean adults, which I think is a good number to make a conclusive findings. They categorize the patient into their age group, and then they also look into the mean and median number of teeth present. So let's say in this age group, in general, people having 25 teeth if you look at mean, or if you look at median, 27 teeth present. So if you are in this group age, you have the number of teeth below 27, then they look into all the factors that associated with the number of teeth and what causes you have more tooth loss compared to the median number of existing teeth. Found that men has a higher risk, patient with a lower household income, primary school graduates living in urban area, and uneducated group. I would say all this is not something new. But what we can see over here is the factors that we can say that is modifiable. Okay, here probably is cannot modify lah. So it's the attitude as well, or the practice. People who brush less than 2 times a day has more tooth loss. Current smoker, low HDL cholesterol, hypertriglyceridemia, people in the metabolic syndrome group, so they have a higher risk. So if we want to tackle or we want to provide any interventions to help to reduce the tooth loss, possibly we need to look into the factors that associate with the tooth loss lah. Okay, you want to advise the patient to brush teeth more than 2 times per day, at least 2 times per day. Quit smoking, and this one probably is associated with the medical team on how we can improve the patient's health conditions. So this is interesting. Shortened dental arch concept is actually a concept that proposed that it is acceptable to accept only 20 teeth inside the mouth with 10 occluding pairs from premolar to premolars, and we could accept that there's no additional prosthetic need for the patients to restore the missing teeth posteriorly. Means it is okay not to provide more dental treatment to replace the missing molars and some of the premolars. It is a concept, but whether the concept can be accepted by the patients or accepted by the dentist is actually a different story. So we have evidence to show that dentures may or may not provide more harm. However, we understand that a fully dented patient, it has a higher chewing ability compared to the patient with a shortened dental arch. Then this research come into place that this is quite new, 2022. They invite 20 specialists in restorative dentistry and prosthodontics from UK to ask them about their opinion on the patient with different pattern missing teeth in shortened dental arch. So they ask opinion 2 times. This is called Delphi consensus. Like, what are the treatment options that is okay for the patient in that particular clinical patterns of the tooth loss in a younger age patient and also in an older age patient. In this survey, they have 5 clinical patterns. In each clinical patterns, they provide I think 9 treatment options, 9 to 10 treatment options. No intervention, acrylic, RPD, metal-based RPD, and then RPD with precision attachment, then RBB, conventional cantilever bridge, and then they have an implant supported crown, implant supported bridge, and then implant supported dentures. All these treatment options. So they provide treatment options on each clinical category, and the young patient and old patient, and then for each they ask clinicians to rate the appropriateness of the treatment on this particular case. So it's a Likert scale from 1 to 9. Lower score is inappropriate, higher score is highly appropriate. So they use the modified Delphi analysis. This analysis is actually, we want the experts to come into agreement by asking them the questions in several rounds, in this case 2 rounds, and to get their answers, their feedback, and to reach shared decision or consensus of like what treatment options is appropriate for this type group or inappropriate for this type group. So this, at the end of the day, they come into a consensus. Just agreement based on their available evidence and their clinical experience. In this situation, the consensus doesn't mean the correct answers, but it means like most people agreed that this and this and this. So this is a judgment or agreement that has been found. However, the author also mentioned that the patient's preference, needs, experience, and conditions should take into considerations when making a decisions. So let's look at this summary that I made based on the research. Actually, the research are very long. This is just like I pick up some of it. So for each category, this is a patient above 65 years old. In the patient in this clinical situation, they give 9 types of treatment. So to find out which is appropriate or which is inappropriate. So if the treatment not listed here, which means they couldn't reach any consensus whether they should provide or shouldn't provide that kind of treatment options. Okay, so very common, very classic SDA patient with present 5 to 5. Elderly patients, they all agree that it is appropriate to provide no intervention. And they agreed that it is inappropriate to provide acrylic dentures, RPD with precision attachment, conventional cantilever bridge for this group of patients. So for the second scenario, which you have missing all molars, additional to that, you're missing 1 premolars. There's no consensus of what is appropriate to provide for the patient. However, they come to consensus that acrylic partial dentures with precision attachment, conventional cantilever bridge is inappropriate for that. So this is further reduced. The patients only present from the first premolar to first premolars. Similarly, they couldn't come into consensus like what is provide or what is appropriate to provide for the patients. Some agree, some not agree, but they agreed that this RPD with precision attachment and conventional cantilever bridge is inappropriate treatment options. This is just opinion based lah, okay? So with patients with like more missing teeth, you further lost more premolar. Then you lost one more premolar, you missing both second premolar and all molars. In these kind of cases, we have more missing teeth. Even though patient is old, they come to consensus that dental implant crowns and bridges are actually appropriate treatment options to provide for them. However, conventional cantilever bridge is inappropriate treatment plan. And then further deteriorate, this is a severe SDA case. So the appropriate treatment plan would be cobalt chrome RPD, would be dental implant supported crown, implant supported bridge. So what is inappropriate, which is cantilever bridge and also resin bonded cantilever bridge. Right, so this is for the elderly patients. And this is for the younger patient, younger group. Okay. I won't go through each and every one. You can read the journal and also the supplementary materials that attach to the journal. There's a link there, not the link, the name of the journal here. It's a free access. But you can see in the younger patients, actually they come into consensus like, dental implant treatment should be provided for this group of patients, even when the patient just missing one premolar and all molars. So they think that implant supported crowns is actually an appropriate treatment plan for the patients. And as you can see that acrylic RPD is inappropriate, then and goes to the rest of the treatment, especially the conventional cantilever bridge lah. As a conclusion, we can say that currently is insufficient evidence to recommend the best tooth replacement strategy in the adult patient with this reduced dentition. As we know that the SDA may lead to reduced chewing performance. However, people with stable remaining teeth, they can adapt over the time and they can still eat most of the food, and generally they are satisfied with their chewing ability. Tooth loss may lead to the tooth movement and eventually changes in the occlusal contact, but individuals typically adapt to the new equilibrium state. The bilateral and unilateral free end RPDs have already shown that it do not really improve the masticatory functions, the patient satisfactions, or the oral comfort. And in some cases, the denture may also have the adverse effects on the soft tissues or hard tissues. However, these dentures are actually indicated in the severe shortened dental arch cases where this patient, we know that the oral function is significantly impaired. Dental implants are the common alternative to SDA. They are conservative long-term than these long span bridges. The dental implants help to preserve the bone and they provide a better posterior support compared to dentures. However, they are the most expensive options. So this SDA, the aim of the SDA concept is to preserve not less than 20 functional teeth without having any prosthesis for oral functions and oral comfort. This concept is widely accepted by the clinicians, the patients, and healthcare authorities for many years. This is partly due to the growing numbers of the elderly patients who still have their teeth. And I would say that economy factors is the main important reason of why making the SDA still appealing to the patients, because of the limited resources for the treatment. And this SDA concept, it still deserves to remain as one of the treatment options when you don't see any evidence against its use. So these are additional reference if you would like to refer to. Finally, I have one survey which I posted in the UKM folio. So you are invited to provide your opinion on the treatment options presented for various clinical scenarios. Okay, this one I only focus on the elderly patient, okay, above 65 years old. And then once you provide your opinion on each questions, you will be able to see what are the consensus or agreement by the UK experts in the research that I showed just now. What do they say about it? Okay, so some of the question they may not reach consensus, which means they have people support this treatment option, or they have experts who disagree. I think that is inappropriate. However, you can look at the score, the medium score. Let's say if the medium score is 6, 7, 8, 6, 7, so which means there are more people who actually support that these treatment options are appropriate, even though they have not reached agreement of 70%. Right? Then if the score, the medium score are among 1, 2, 3, 4, means is under the inappropriate category, even though they have not reached a consensus above 70%. But if the medium score fall between 1 to 4, you also roughly can guess that more experts actually think that treatment options are inappropriate. So enjoy the quiz. If you got any questions, please let me know. Later I'll show you another screen sharing of the UKM folio of what you expect to see in the survey and how you interpret the result. So this is my UKM folio. It might appear slightly different in my side and also your side. You can find this under shortened dental arch, opinion on appropriateness of tooth replacement treatment. So there are a total of 36 questions. So these are the pattern of missing teeth. Patient have a teeth present from 5 to 5 in the patient age 64 and above. Okay, so the treatment options is to provide no intervention. So you think that in this patient, elderly patient, is no intervention and appropriate treatment options or not? So if you think is inappropriate, you just click here, okay, until 9. So I would say it's highly appropriate lah, because patient already so old, okay, and then patient have minimum teeth present from the premolar to premolar, okay, assuming like upper dentitions are good lah, okay. So I choose highly appropriate. Then check. So this is my feedback. You may receive marks, but you just ignore the marks, okay. So in the first round of the Delphi survey, okay, the expert agreed that no intervention is appropriate, and 78% of them agreed that no intervention is appropriate, okay, with the mean score at 8. So a lot of people choose 8 lah. Then question 2, so how about acrylic partial denture? I think give dentures in the elderly patient, some more acrylic, probably not so appropriate good. Then I check. Then you read on the feedback, okay, they found that acrylic partial denture is inappropriate. So 79% of them agreed that is inappropriate lah, okay, with the mean score at 2. So a lot of people choose very inappropriate, right? So there's no right or wrong answer. It's just that you see whether your treatment choice similar to the 20 experts in UK or not. So I think that's the end of the lectures. Once you completed that, this so-called questionnaire or survey, I considered you finished or you attended the lectures, and I will take attendance for that. Thank you.